I hope that you can hear me. Cool. Thank you, Alisa, and thank you, everyone, for being here today. As Alisa was mentioning, we will start in a few. I just want to wait only a little bit, but I do think that we have to keep going because we all are so busy. We already know that you connecting on time, so I do think that we can start, right? So, good morning, good afternoon, even good evening to everyone, and welcome to our PGT-A Plus Webinar Series Part 1, New Findings on the Incidence of Haploidy and Triploidy in Trophectoderm Biopsies. For those who doesn't know me, my name is Nasser Al-Asmar, and I am Embryo Product Director and Senior Scientific Advisor in iGenomics, part of VitaLife Group in Valencia, Spain. And first of all, I would like to say hi to all of the attendees who are joining us today from North America mainly, but also from other places like South America, Europe, and Africa. A warm welcome to everyone, and thank you for joining us. Just want to make a small comment regarding our group. I guess you already know it, but I think it's worth it just to comment that we at Genomics are under the umbrella of VitaLife Group. And as you may know, at VitaLife Group, we do have the most extensive portfolio on the field for helping you and your patients to achieve their productive goal. And no, it's not to get a patient pregnant, but to have a healthy baby at home. For that purpose, we have genetic laboratories and production sites all over the world, as you can see in that slide. You can observe that we are processing samples with different ethnicities all over the world to give you our best. But let's move with the agenda. Today, we will start with an introduction regarding what are ploidy abnormalities, triploidy and haploidy, from my colleague and friend, Dr. Lisa Snyder, that is the Genomics Director of Clinical Genetic Services. After that, we will have also a friend and colleague, Dr. Angela Linville, a Genomics Medical Science Liaison Genetics, that will give us some interesting data regarding our experience with ploidy analysis by SNPs, extracted from Dr. Laura Girardi's paper published in Journal of Assisted Reproduction and Genetics back in 2024. Last but not least, we will finish with a Q&A session where we will take questions from the audience. And for this purpose, please write your comments and questions in the Q&A box. You don't need to wait until the end of the session to start asking questions. So please don't be shy and share with us your thoughts. So let's start with a short introduction. And as I mentioned, our first speaker is Dr. Lisa Snyder. Dr. Snyder is a PhD geneticist and certified genetic counselor. Dr. Snyder is the Director of Clinical Genetic Services at iGenomics, where she helped grow the company since its inception in the United States. She directs iGenomics clinical genetics testing services, including PGT-A and PGT-M, and oversees the genetic counseling department. She is the Vice Chair of ISRM's PGT Special Interest Group, a past chair of ISRM's Genetic Counseling Special Interest Group, and a past chair for the National Society of Genetic Counselors IRT Infertility Special Interest Group. Alisa's lecture will be followed by Angela's lecture. And to ensure a smooth transition, let me introduce you now Dr. Angela Linville. Dr. Linville is a PhD geneticist with over 15 years of experience in the IVF and genetic testing industry. Since 2020, Dr. Linville has worked as a medical science liaison at iGenomics, supporting U.S. clinics through the Medical Affairs Department across the full genetic portfolio, with a specialization in embryo genetic testing. So now, I guess, Elisa, it's your turn. Whenever you want, the floor is yours.
Thank you so much, Nasser. Give me a quick thumbs up that you can hear me. Awesome, sounds good. Well, hello, everyone. It's my pleasure to speak with you today about PGT-A Plus and ploidy detection and tell you a little bit more about what ploidy is. Just to start, I wanted to share with you that we're here for a reason today, and that is in response response to a call for more client and patient education. iGenomics recently conducted a market research project. It was a double-blinded research study where we surveyed users of PGT-A, both iGenomics users and non-iGenomics users. We surveyed 20 individuals that included REI physicians and medical directors, as well as embryologists and laboratory directors. And some of the key findings were listed here. The first one here being that there's an urgent need for more patient and clinic education around PGT-A. So we heard you. That's why we're here today. We want to provide more education around PGT-A, specifically around our new offering of PGT-A Plus that includes ploidy detection. One of the key findings was that clinicians uniformly see the value in detecting ploidy for PGT-A testing. So ploidy is a clinically significant finding that may not be picked up with regular PGT-A, but it can be detected up with advanced technologies. Most clinicians also recognize the value in embryo QC features, which will be the focus of our part 2 of our webinar series. Again, more education is necessary around these QC features to fully understand its utility and value. Another key finding, which we will spend quite a bit of time emphasizing today, is that it is not well understood that a small percentage of euploid embryos can be triploid or haploid. I just mentioned it, triploidy and haploidy may not be detected depending on what kind of technology you're using, and it's not going to be picked up with NGS alone. And the other key finding, which Angela will spend her time addressing, is that not all clinics culture abnormally fertilized embryos to blastocyst. Some of these embryos are not considered for use and they are immediately discarded, whereas other clinics will culture these to blastocyst, biopsy them, and send them to the PGT-A laboratory for testing, some knowing the limitations of their current technology, some not knowing. So we'll address how to manage this situation in this webinar. So first we'll start answering this question of what are ploidy abnormalities? And here we're going to be focusing on triploidy and haploidy. So ploidy refers to the number of chromosome sets in a cell or in an individual. We want to see diploidy. This means that there is biparental inheritance of one set of chromosomes, of two sets of chromosomes, one originating from the egg and one originating from the sperm. There's also haploidy, where there's only one set of chromosomes. So here is listed haploidy 23X, and you can see that there are just one copy of every chromosome 1 through 22, and then chromosome X. Triploidy is when there's 3 sets of chromosomes for each of the autosomes 1 through 22, plus the sex chromosomes. You can see here that this is listed as a 69XXX embryo. Triploidy and haploidy are both compatible with preimplantation embryonic development. So these may be the genetic composition of embryos that successfully developed to blastocyst stage. However, they are not compatible with development to term in most cases. The exceptions would have babies that have multiple congenital anomalies. Triploidy is a common cause of miscarriage, especially in the second trimester. So about 10% of chromosomally abnormal spontaneous miscarriages are found to have triploidy. I wanted to take a little bit more time to review the phenotype of triploidy. Most of us generally know that triploidy is an abnormal chromosome composition and it's not compatible with life, but it can result in clinical complications with pregnancy. So triploidy is the genetic cause and etiology of molar pregnancies, specifically diandric triploidy. So diandric triploidy is where we have 2 sets of chromosomes coming from the sperm and 1 set of chromosomes coming from the egg. That's what underlies a partial molar pregnancy. This is very commonly caused by the fertilization of an egg with 2 sperms, so we call this dispermy. So in spontaneous pregnancies, diandric triploidy is the most frequent cause of triploidy. In the IVF space where ICSI might be used, dispermy is less common, and you might have triploidy that originates from other mechanisms, like a diploid egg or a diploid sperm. So those can happen as well. If you have a diploid egg, which would cause digynic triploidy, the phenotype of this is actually not a molar pregnancy. Pregnancy can result, but it would result in a fetus that is underdeveloped with macrocephaly and other multiple congenital anomalies. So neither diandric nor digynic triploidy are good. We want to avoid the transfer of these embryos whenever possible. Haploidy can be compatible with embryonic development to the blastocyst stage, but it's not expected to result in implantation or miscarriage. In fact, we don't see haploidy reported on POC testing for genetically tested miscarriages. There's another chromosome abnormality, paternal diploidy, which can cause your complete molar pregnancy. So the partial molar pregnancy is usually caused by diandric triploidy, two sets of chromosomes coming from the sperm. A complete molar pregnancy also has two sets of chromosomes coming from the sperm, but it doesn't have a chromosome set coming from the egg or the maternal source. Paternal triploidy is genome-wide paternal UPD, which may be observed as haploid using molecular detection methods such as NGS. Why? Because you have a complete duplication of the paternal set of chromosomes. So this could be endoreduplication of the sperm. So you don't have any heterozygosity in the SNPs or any other polymorphic markers that you're looking for. So when we're testing embryos, it might look like haploidy, could be haploidy, but it might also underlie paternal diploidy or genome-wide paternal UPD, which would be the genetic cause of a complete molar pregnancy. So did you know that next generation sequencing cannot detect triploidy or haploidy? I think that this gets confused because everyone knows that when we're doing PGT-A testing, we're looking at chromosomes. We're trying to get an idea about how many chromosomes are there, looking for extra or missing chromosomes. So if there are 23 extra chromosomes or 23 missing chromosomes, why can't we detect it? And I will spend the next few slides answering that question. But this is going to be one of the take-home messages from today's webinar, is that ploidy abnormalities may not be detected by PGT-A, and it would depend on what kind of technology you're using. Without PGT-A testing, we try to get an idea about the ploidy status based off of the number of pronuclei that can be observed during the pronuclear check. When we see two pronuclei, we think that there's one set of chromosomes coming from the egg, one set of chromosomes coming from the sperm, and we have a diploid embryo. If we only see one pronucleus, we suspect that there is only one genome coming from either the egg or the sperm, and that this could be a haploid embryo. When we see three pronuclei, we think that there are three gamete genomes coming together, and that this could actually be a triploid embryo. So the 2PNs are what we consider normally fertilized oocytes, whereas the 1PNs and the 3PNs are what we would call abnormally fertilized oocytes. You might hear this referred to as an acronym of AFO. These comprise about 10% of oocytes in the IVF laboratory. They're often discarded or not considered for continued culture because of the risk of ploidy abnormalities. So in terms of use of embryos, obviously we feel very comfortable with 2PN embryos. These are the ones that we consider to be diploid and capable of normal growth and development. Based off of the fertilization check, if there's abnormal fertilization, we begin to worry that there could be abnormal ploidy, and our confidence in being able to use these embryos decreases. When we look at 0PNs, pronuclei can be sneaky. Maybe we just missed it. Very often at the pronuclear check, we just didn't see the pronuclei when we needed to see them. Very often these are actually diploid embryos, and we can feel fairly comfortable developing and culturing these embryos to blastocyst. our confidence in being able to use abnormally fertilized oocytes begins to decrease as we go from the 1 PNs to the 3 PNs. And in the middle here, you'll see a 2.1 PN. This means it looks like possibly a 3 PN embryo, but the third pronucleus is small, and it's not entirely clear if that is actually a pronucleus or some other granular piece of the embryo that we're not sure what we're looking at. So let's talk a little bit about what we can see with PGT-A by NGS. So not including any SNPs yet, this is the NGS that we've been using for the last several years, the basic PGT-A test. What can we and can't we see with NGS? So PGT-A is an embryo prioritization or a selection tool. Essentially, we're trying to get at the chromosomal status of the embryos to help us decide which embryos to transfer and in what order to transfer the embryos. After the egg and the sperm come together, each with 23 sets of chromosomes, we expect there to be 46 chromosomes. What NGS does is it looks at the relative copy number variation for each chromosome. So we're not actually looking at a karyotype like those pictures that I showed you before. We can't see a picture of the chromosomes. It's a sequencing-based technology and platform, and the number of reads that you get is semi-quantitative, and it's placed on a plot, which I'll show you in the next slide, which gives you an idea about the copy number for each chromosome. But it's important to emphasize that this copy number is normalized to copy number 2. And this is how we can get at copy number variations for chromosomes regardless of how many cells are biopsied. So if we look at 2 cells or 5 cells, we need to have an idea about how many chromosomes are in that biopsy, independent of how many cells there are. So the amount of DNA that's sequenced is normalized, and it's assumed to be copy number 2. A euploid embryo will show no copy number variations, and an aneuploid embryo will show a copy number variation for that chromosome compared to the rest. You may have seen these before. So these are typical profiles that are generated after next generation sequencing showing euploid embryos. On the top, you'll see euploid female embryos, a euploid female profile. So for all the autosomes 1 through 22, you're going to see that they are normalized to copy number 2. Please look at the sex chromosomes here. There is no sequencing read for chromosome Y. And when we look at chromosome X, it looks like there are 2 copies of chromosome X, the same as for all of the other autosomes that were screened. For a euploid male, you're going to see the autosomes 1 through 22 aligning at copy number 2. And again, please look at the sex chromosomes over here. You will see reads appearing for chromosome Y appearing at copy number 1, and reads for chromosome X appearing also at copy number 1. So half as many reads for chromosome X and Y as for the rest of the autosomes. So this is a relative copy number change. When we look at aneuploidies, we can see that the relative copy number for one of these chromosomes is altered. So for chromosome 16 here, you will see this elevation showing up at copy number 3. This is what we would call a trisomy for chromosome 16. It's relative to the rest of the autosomes, which are normalized to copy number 2. And we can detect more than one change. So at the bottom profile here, we see a complex aneuploidy with 5 different chromosomes involved. So you see that for those chromosomes, there are clear elevations at copy number 3 or clear depletions at copy number 1 for the impacted chromosomes. So now we're going to talk a little bit about how ploidy looks with next generation sequencing. So here again is a diploid embryo, 46 chromosomes. This one's male, so you're going to see X and Y. This is what a male profile looks like as shown in the previous slides. Here I kind of chopped off the first chromosomes for simplicity. So we have autosomes 10 through 22, but also the sex chromosomes aligning at copy number 1, half that of what we see for the autosomes. On the far right, we have a triploid cell, so 3 copies of every chromosome, and you'll have 2 X chromosomes and a Y chromosome. So if we look down here at the profile for a triploid embryo, we do see some copy number variations for the sex chromosomes that are different than what we would see for the euploid male. And when we're talking about copy number variations, when they are intermediate, this is often what we would think of as mosaic. So if this was a cell or an embryo that was mosaic for the sex chromosomes, it could look like this profile too. Sometimes we call this profile a stepwise XXY profile. Stepwise XXY profiles can underlie triploidy. There's other explanations for this, such as contamination. So NGS can see differences in the sex chromosomes for male triploid embryos, but there's other explanations for this profile too. It's not only 69XXY, which is why triploidy, even for male triploidy, remains a limitation of NGS testing. I wanted to differentiate 47XXY from triploid 69XXY. So trisomy, this is also what we call Klinefelter syndrome for the sex chromosomes. We'll have disomy for all the two, diploidy, sorry, for all the two chromosomes, all the autosomes 1 through 22, but then there will be an extra sex chromosome. So this is a diploid embryo, but instead of seeing this stepwise XXY profile, you will see chromosome X aligning at copy number 2. So there's 2 copies of all the autosomes, 1 through 22, 2 copies of the sex chromosome, or the chromosome X, and 1 copy of chromosome Y. So the copy number variation for chromosome X, the same as for all the autosomes, and the copy number variation for chromosome Y is half that of chromosome X and the other autosomes. So these profiles are distinct, you can see them, but still triploidy cannot be directly detected by NGS because of alternative explanations for this profile. Then when we look at female triploidy, it's a complete limitation. You can't detect it with NGS at all. Neither can you detect haploidy, and I'll show you why. So again, here we have a diploid cell, diploid embryo with 2 copies of every chromosome with 2 X's. This is what we would call female. When you look at triploid 69XXX, this is what we would call female triploidy. There are 3 copies of all the autosomes and 3 copies of chromosome X. All of that says that there are no relative copy number differences for any of the chromosomes. We assume that the copy number is copy number 2. It's normalized to copy number 2. We don't see any differences, so it looks identical. This profile here would be exactly the same for a diploid 46XX embryo as for a triploid 69XXX embryo. And the same thing would be true for this haploid embryo here in the middle, 1 copy of every chromosome, 1 through 22, 1 copy of chromosome X. There are no relative copy number differences for any of these chromosomes. So you would have the exact same profile, which looks like a euploid embryo for all 3 of these situations. So for male triploidy, you might be able to see some signs or suggestion of triploidy while not being able to detect it directly. For female triploidy, you're not going to see it at all. It will be completely missed, and there's no sign or suggestion of a ploidy abnormality with NGS testing alone. So I wanted to emphasize that while I'm saying that ploidy is a limitation of PGT-A with NGS, that the whole chromosome detection is still as you know it, as has always been. If whole chromosome aneuploidy is in the uniform range, so not segmental or not mosaic, it has high predictive value for the whole embryo, including the inner cell mass. And this is backed by extensive validation studies that iGenomics has published. A few of them are listed here. You can check them out. But there's been extensive validation of our technology, our platform, as well as the proprietary algorithm that we use to call chromosomal aneuploidies. And here's kind of a clinical situation that we see with NGS without the addition of SNPs. So going back to this stepwise XXY profile, so you see copy number 2 for all the chromosomes, an intermediate copy number depletion for chromosome X, and intermediate copy number depletion for chromosome Y. So the reads for chromosome Y are actually below that of copy number 1. Why? Because if it's triploid, the relative proportion for chromosome Y is going to be 1/3 of that of all of the autosomes. So 3 copies of all the autosomes, 2 copies of chromosome X. So X would be at 2/3 of the rest of the autosomes, and Y would be at 1/3 of the rest of the autosomes. This is what we call stepwise XXY, showing intermediate copy number variations of those chromosomes. Fortunately, the frequency of this is low. We see it in only about 0.3% of all of the PGT-A results that we run without NGS. And again, I just want to emphasize that this does look like triploidy. We can see it, but there are other explanations for this kind of profile. I mentioned sex chromosome mosaicism. It's actually an unlikely explanation. We don't see sex chromosome mosaicism that often. If it's something like a Turner syndrome mosaicism, we would see X at copy number 2, and then Y would be at copy number 1, and X would actually be a little bit depleted. So there are signs and suggestions of sex chromosome mosaicism, but it's not a common explanation for this kind of profile. Another explanation that we can see for this kind of profile would be contamination. So if you have a euploid male embryo with cumulus cell contamination, for example, that could give you a profile that's somewhat similar to this. And that contamination and the need to differentiate between a contamination call and a triploid call will be the focus of part 2 of our webinar series. But because the interpretation of this profile is not super clear, rebiopsy is the recommended approach. After rebiopsy, if you see the same result again, we can be confident that this is indeed a triploid embryo. If it's because of contamination, you'll see that contamination resolve, and instead of seeing this stepwise XXY result, you would then see a euploid result without the stepwise XXY. So we've been suggesting rebiopsy for stepwise XXY embryos for some time now. We recently did an analysis to try and figure out the frequency of embryos that came back as with the same stepwise XXY profile and were then interpreted as triploid. So within the last 2 years, there was 157 embryos with stepwise XXY results that were rebiopsied. As expected, many of them were triploid. We found that about 3/4 of them had the same stepwise XXY profile again and were interpreted as triploidy. While it was the majority, it certainly wasn't the rule. There are exceptions. So not all of these are going to be triploid. Some of them are going to be euploid or other diploid results on rebiopsy. So about 17.8% of them came back as euploid, of which 93% were male. This is why we think that the majority of these profiles that are not triploid are actually male embryos with cumulus cell contamination. And these would be embryos that are candidates for transfer. So this distinction between triploid don't transfer and euploid male candidates for transfer is really important to us. We don't want to use PGT-A testing to exclude embryos that have reproductive potential. So it's very important to not overdiagnose triploid. We really want to be confident in this result. And being confident in this result with NGS alone would require a rebiopsy. Not ideal because rebiopsies are costly. We don't charge for rebiopsies of these, but the clinics often charge. The patient might have to pay extra. Or at a minimum, the time and labor is costly to thaw the embryo, rebiopsy it, and refreeze it can be quite an ordeal in the clinic. So this is a good reason to use a PGT-A testing platform that has not only NGS, but that also has SNPs so that you can get that ploidy, that triploid call on a first biopsy without the need to do a second biopsy. Which brings me now to PGT-A Plus. We're going to talk a little bit more about technology. It's evolved rapidly over the years. So starting in just 1995 in the world of medicine, this was not that long ago, we were biopsying day 3 embryos performing PGT-A testing on a single cell and looking for only about 5 to 12 chromosomes using FISH, fluorescent in situ hybridization. More effective methods started to emerge in the 2000s. So by 2008, we were looking at a more whole genome approach, looking for all 24 chromosomes using various different techniques, including array CGH, SNP arrays, or even qPCR. In the around 2013, 2017, we began to use next generation sequencing, which was more high throughput, more cost effective for patients. And we also began to use embryoscopes to get an idea about time lapse, how the embryos were developing, and to be able to refine the fertilization check. And now in 2023, we've incorporated SNPs into our PGT-A testing platform to enable ploidy detection, as well as these embryo QC features. We have a cohort check and a contamination analysis, which we will be focusing on in our next webinar. What are SNPs? SNPs are single nucleotide polymorphisms. This is a change in the DNA sequence. These changes are not pathogenic, they're not disease causing, they're what we call polymorphic, so they happen to be different person to person. I think it's important when you're thinking of SNPs to realize that there's usually only two different alleles. So this might be a T, it might be a C. And we call these alleles just roughly A or B, and B is usually the minor allele. So when we're talking about the B allele frequency, we're talking about the frequency of B compared to A, which would be the major allele or the one that's most frequent. So let's say that in a diploid embryo, you're looking at a particular locus. If that locus has two A's, the B allele frequency would be 0, or the B allele fraction would be 0. If we're looking, if we see BB, homozygosity for the minor allele, then B would be 100% fraction. If we're looking at a heterozygous situation where we have A and B, B would be 50% at that locus. And then we look at a multitude of SNPs and we determine the B allele frequency across all of the different SNPs that we're looking at to give us this distribution. So how many SNPs are heterozygous, how many SNPs are homozygous for B, and how many SNPs are homozygous for A. So this is a characteristic allele frequency distribution plot for diploid embryos. When we look at triploid embryos, you can begin to see how we can use these allele frequencies to detect it. So similarly, if we have homozygosity, your B allele frequency will be 0 or 100. And if you have something in between, like let's say AAB, then B would be 33% at that locus, or if you have ABB, B would be at 66%. So if you have a multitude of SNP loci and you're looking at the B allele frequency over these multiple loci, you're going to see peaks in this distribution plot, not at 0, 50, and 100 as you would for the diploid embryos, but at 0, 33, 66, and 100 for the B allele frequencies. And so these distribution plots are what we use to detect triploidy and contrast that to diploidy. So it's my pleasure to introduce to you, if you haven't already met, our Smart PGT-A Plus platform. This is our most advanced 4-in-1 genetic test that offers increased accuracy and confidence for embryo transfer. So it includes Smart PGT-A, it still includes the NGS testing that we've been using before, and it adds on the other layer for SNPs that allow us to detect ploidy. And as we learned in our market research, clinicians uniformly see the value of being able to detect ploidy on a PGT-A platform. The fun part about SNPs is that it allows us to do additional QC features. So we are also able to detect contamination, and we're also able to compare the genetic relatedness between embryos in a cohort to give us extra confidence that the embryos originated from the same egg and sperm source. Just to compare and contrast, Smart PGT-A and Smart PGT-A Plus, they're very similar in technology. The difference is these SNPs. So they both use NGS, Smart PGT-A Plus will also incorporate SNPs. Both tests look at aneuploidies, mosaicism, segmentals, and has an accuracy of 98%. Including SNPs increases the accuracy just a smidge. We have more confidence in those results because we can catch some missed triploidy or haploidy that can cause miscarriage. And it can also help us catch a few situations where there's been a procedural error. Both tests also enable MITA-score reporting as usual. And then the SNPs also allow us to do these add-ons, the contamination check and the cohort check. And I believe that brings me to the end of my slides. I'll say farewell to you at the end of the webinar, but I'd like to bring on Angela Linville to discuss our experience with ploidy analysis by SNPs.
I'm sorry to interrupt, Angela, and jump in, and thank you, Alisa. But I would like to encourage our audience. We have around 200 people live right now, and I would like to encourage them to ask questions, to start writing in the questions box, because we just have one so far. So please share with your thoughts with us. Don't be shy, and yeah, let's do that. So thank you, Alisa and Angela. Whenever you want, your turn. Thank you.
Great. Thank you. So in follow-up to Alyssa's introduction, I wanted to focus a little bit more about our experience with ploidy analysis and using SNPs to, in addition to a next generation sequencing platform, to be able to identify these different ploidies that Alyssa was talking about. So again, just to emphasize what Alyssa was saying is that standard NGS cannot detect all forms of triploidy. So in this paper that I'll be reviewing, which was published by Giardi et al. End of last year in 2024 in the Journal of Assisted Reproductive Genetics. We will be going into, let me switch slides here. There we go. The paper is titled The Incidence of Haploidy and Triploidy in Trophectoderm Biopsies of Blastocysts that were derived from both normal and abnormally fertilized oocytes. So really diving into the differences and seeing what we can see in terms of ploidy for the normal 2PN embryos, and then also if we can identify diploid embryos and those embryos that are identified to be the 0, 1, 2.1, or the 3PN. So the purpose of this paper was to identify a correlation between a morphological PN check and also the genetically determined ploidy analysis with SNPs. So this is an overview of the study design. So initially, all the embryos underwent a PN assessment first. So they were categorized into these different categories you see here. So normally fertilized embryos, the 2 PN embryos that Alyssa was talking about, two clear pronuclei, were categorized as 2 PNs, normal fertilization. And then the other category was abnormal fertilization. So this is where we go into the 0 PN, the absence of a pronuclei, and then the 1 PN where we see a single pronuclei, and then the 2.1 and the 3 PNs. And this paper, we did distinguish between the two, and it's interesting in talking to different clinics in the US, these aren't always categorized this way. Some clinics, 3 PNs, the 2.1 PNs as a 3 PN, and that Sorry, I think my computer disconnected for a second, so hopefully you can hear me now. So what I was saying is that the 2.1 and the 3 PNs were designated differently in this study, and it'll be a little bit more apparent why they did that when we see the results. So all of these embryos, whether they were normally fertilized or abnormally fertilized, they underwent the first level of analysis, which was by NGS. So as Alyssa explained, NGS is very good at detecting whole chromosome aneuploidies that are either one or multiple that are seen in a profile, but it cannot detect embryos that have changes in whole chromosome sets, such as triploidy or haploidy. Those would appear euploid. So the euploid embryos that were found on NGS underwent a second level of assessment, and in this assessment, we used SNP analysis, and this was to designate if they were diploid, haploid, or triploid. So the first data set, this is looking at specifically just the 2PN embryos. So the embryos that were assessed at the beginning, seeing 2 pronuclei, and what is the incidence of triploidy or haploidy in a 2PN embryo. Historically, in other studies, we've seen that these embryos are most likely diploid, and in this case, it was very similar. So we had 1,982 normally fertilized embryos that were 2PN, and 99% of these were found to be diploid. However, 1% were found to not be diploid. So the triploid embryos were found at a rate of 0.8%, and haploid embryos were found at a rate of 0.2%. So even in normally fertilized 2PN embryos, we do see some cases of haploidy or triploidy. So that is important to note that it is possible to have a triploid or haploid embryo, even if you visualize a normally fertilized 2PN embryo. So this next data set looks at the other side. So now we're looking at the abnormally fertilized embryos that were categorized as the 0, 1, 2.1, and 3PNs. And these embryos were found to be euploid by NGS, in addition to having the abnormal fertilization that was assessed in the first part of the study. So if we take a look at the 0PN embryos, there were 150 of them in this cohort. And what we found is that a majority of them were actually diploid. So 87.3% were diploid, which is in line with what Alyssa was saying, our comfort level of using 0PNs. Most likely it was missed on FERT check. The majority of these are found to be diploid, with a small percentage of them being haploid or triploid. If we move to the 1PN embryos, we had 153 of these embryos, and approximately 45.8% were found to be diploid. And similarly, haploid embryos were found 47.7% of the time. And a small percentage of these were found to be triploid. Again, in line with clinic's usage of 1PN embryos, we do see a little less than half of these actually being truly diploid. But if we look at the 2.1 PNs and the 3PNs, so at the beginning I mentioned that we do categorize these a little bit different, and the results show that there is a difference between diploidy between these two categories. So for the 2.1 embryos, we found that 65.2% were actually diploid, with the remaining third being triploid. And that's in contrast to what we saw with the 3PNs. For the 3PN embryos, we did see 3/4 of these to be triploid, with 1/4 of them to be diploid. So an important take-home message from this slide is that out of the 380 euploid embryos by NGS, we were able to identify an additional 230 euploid diploid embryos that may not be considered for transfer. And in talking to or mentioning what Alyssa had said earlier, not all clinicians or clinics utilize these embryos. So I would like to bring this to everyone's attention who's potentially not using this kind of technology now. Patients with limited embryos or patients that have abnormally fertilized embryos, using this type of technology could potentially give them more options for transfer. So the other part of the study, they looked at the impact of time-lapse culture on the correlation with ploidy results. So the difference between a static observation for PN check and time-lapse observation is that static observation, you're really only seeing one point in time. And in some cases, like for a 0PN, that PN check could get missed and get classified as a 0PN. When we look at time-lapse, we're looking at multiple time points throughout the embryo's development, potentially a more accurate assessment of PN status. So what this table is showing is the ploidy predictivity for the pronuclear status according to the type of PN observation. And what they found is that the predictivity, as we would expect, is much higher when you're looking at time-lapse, and it correlates much better to the genetic PN check than it would for a static observation. So we're looking at 80.4% for time-lapse versus static observation, which was at 28.3%. And these numbers will reflect in the data that I'm going to show on the next slide. So in this slide, it's laid out similarly to the one I showed before, but now these are all embryos that were assessed by time-lapse. So there were 51 embryos that were analyzed by NGS and found to be euploid. And looking at the data you see with the 0PN embryos, there were 8 of them in this cohort. We found 100% of them to be haploid. So this is different than what we saw with static observation in the previous slide, where majority of them were actually found to be diploid. So 100% of the embryos were haploid, that were 0 PNs. And then moving to the 1 PNs, in these 16 embryos, we found that 68.7% were truly haploid, but we did find the remainder of the embryos, around a third of them, to also be diploid. And looking at the separation again between the 2.1 and the 3 PNs, we have 2/3 of the embryos in the 2 PN category to be diploid and the remainder to be triploid. And with the 3 PNs, majority of them were truly triploid, but we did see 12.5% to be haploid. So in this smaller data set, we still found the additional use of 10 euploid-diploid embryos that may not have otherwise been considered for transfer. So even with the higher accuracy with time-lapse, there is some benefit to adding a SNP platform to your NGS PGT-A test to be able to identify the truly diploid embryos, even if they're abnormally fertilized. So I'd just like to finish with kind of the next natural step when you think about these is what are the clinical outcomes and do we have any information on outcomes transferred from embryos that were initially assessed as abnormally fertilized but then found to be diploid. And there are 2 papers from the end of the last year, and I'll just put them up here just to show you some of the data. So the first paper here are looking at specifically the 2.1 PNs that were found to be diploid. And you can see that there are live births that have happened, clinical pregnancies and live births that have happened from the transfers of these embryos. So they specifically only looked at the 2.1 PN embryos. But the second paper, it's a little bit of a bigger data set, but still small numbers. They looked at embryos that were 0 PN, 1 PN, and 3 PNs, and they also saw pregnancy and live births from these embryos. So there is more data to come. iGenomics is actively working on this with clinics here in the United States to be able to gather this outcome data, and hopefully soon we will have more information on this. So I just want to touch back and circle back to what Alyssa had presented earlier with our comfort level in using these embryos. So we are most comfortable with the 2 PNs, most likely to be normal because we see 2 clear, distinct prenuclei in the embryo. And then our comfort level decreases when we don't see any prenuclei or we see different numbers like a 1, 2.1, or a 3 PN. So what I like to highlight here is that with a SNP analysis, this could actually increase our comfort level with using not only just the 2 PNs, but also some of these abnormally fertilized embryos. Some of these abnormally fertilized embryos, as you saw in the data I presented today, are diploid. And this could be extremely important for patients that have limited number of embryos, or maybe they're only embryos in abnormally fertilized embryo. So this test can increase your patient's chances of having transferable embryos and hopefully having a baby, a pregnancy and a baby to take home. So the overall goal, just to wrap up about ploidy analysis, we have 2 main goals when we're looking at ploidy. So the first one is to increase the diploid candidates for transfer after abnormal fertilization or no fertilization. So this is looking for those diploid embryos that were categorized as an abnormally fertilized embryo, potentially not considered depending on the clinic's practice or what their usage is of these embryos. By using a SNP analysis, this could potentially increase chances for diploid candidates for patients to have for transfer. And the other side of that is to decrease the chances of transfer of embryos with ploidy abnormalities. So the first data set from this paper shows that the incidence of haploidy or triploidy is around 1% in normally fertilized embryos. So this could, using SNP analysis or an NGS platform paired with SNPs, can decrease the chances of transferring a 2 PN embryo that could be haploid or triploid. So just to finish up on some conclusions and main take-home messages from this paper is that these results support adding a molecular method to the standard PGT-A workflow to complement the fertilization checks and confirming embryo ploidy. And again, I think one of the biggest take-home messages is that a molecular ploidy check can be beneficial for giving the opportunity to rescue some categories of abnormally fertilized oocytes and potentially providing more euploid, diploid embryos for transfer. Again, emphasizing that patients who might only have a limited number of embryos, maybe some of these are abnormally fertilized, using an NGS platform with SNPs could potentially increase their options for transfer. And lastly, we generated key data to guide reproductive counseling on diploidy rates, aiming to improve patient decision-making on the use of these abnormally fertilized oocytes. And with that, I will pass it on to Alyssa to finish up about some genetic counseling.
Thank you so much, Angela. I love that. It's a really impactful and powerful paper. So again, one of the key take-home messages from the market research that we did was that we need more education. So we hope that you found this webinar valuable today. We need not more education just for clinicians. We also need more education for patients and also more information for how clinicians can speak with patients. So I just want to conclude by emphasizing the genetic counseling program that we can offer as a service to clients. There's a QR code here. If you've got your phone, you can take it out. It'll show again on the subsequent slides, but it will take you to our genetic counseling landing page where you will find resources for patient education. You can also find our genetic counseling landing page from our main website. So if you navigate to igenomics.com, click on the genetic counseling tab button, and it will take you to our landing page. It looks like this. So there's a button for PGT-A, click on that. Here you will find these really wonderful PDFs for results guides. There's a general results guide and there's a results guide that's specific for mosaic results. You will find information about ploidy detection and embryo QC in the general results guide, which can be accessed here. Really helpful for patients, also super helpful for clinicians, physicians, nurses, embryologists, etc. It is written in patient-friendly language, so it's not overly complex or detailed. We hope you find them useful. And then, of course, patients can come here to register for their genetic counseling sessions. We have a pre-test webinar that we would recommend for all patients. Please use this service. It's free, it's scalable for us. You'll get a letter that says that the patient attended and what information was discussed. So it's available for patients. If you're a clinician interested in this, you're also welcome to join. Just register yourself as other so that we know that you're not a patient. Patients can also come here to schedule their results sessions with a genetic counselor. Here again is the QR code. You can access it from your phone or go to our website. Sorry, I forgot there was animation here. Forgive me. I think it's really important just to know how to talk to patients about PGT-A, so I wanted to leave you with these key messages for patients. So when we're talking about PGT-A Plus, I'd like to emphasize that this is now considered by many of our clients to be the new standard of care because it does include ploidy detection, which can have clinically significant complications of molar pregnancy and miscarriage. The primary clinical benefit of PGT-A Plus is this ploidy detection. So if you're considering PGT-A Plus or regular smart PGT-A, it's really because of the triploidy and the haploidy detection that's not detected with standard PGT-A technologies. Please, as always, emphasize that PGT-A, like all genetic tests, is optional. So we feel that it's appropriate to offer or discuss PGT-A with all patients, but to really emphasize that it's not a mandated test. They shouldn't feel compelled to do it. PGT-A Plus, like all of our PGT tests, don't test for everything. These are not perfect tests. They do not guarantee a successful pregnancy. And please do let patients know that genetic counseling is available. And with that, we would like to wrap up and answer some questions. Please stay tuned for another invitation for part 2 of our PGT-A Plus webinar series, which will be focused on the embryo QC features, getting at using this advanced PGT technology to minimize misdiagnosis. So that will be coming up on Wednesday, August 13th. Stay tuned. We will send out invitations by email to register for this webinar. So thank you so much. And now, Nasser, if you could please help us with our Q&A session.
Thank you very much, Alyssa. Thank you, Angela, for your wonderful presentations. And thank you all the attendees because we are now full of questions. I have to say, sorry, we cannot go through all of them because of the sake of time, but be sure that we will reply to you directly. We got some questions actually regarding pricing. What's the difference in pricing? We will be happy to share your questions with our wonderful sales team, so they will reach you out and we'll talk about pricing. But let's move with the questions. And this first one, I think, is for both, because in the question, well, there are a couple of them wondering about indication. What would be an indication to perform a PGT-A Plus for ploidy and the other features that Alisa was mentioning there?
Do you want to take that, Alyssa, or do you want me to?
Why don't you start and then I'll fill in.
Okay, so we see usage of PGT-A Plus vary from clinic to clinic. So we would recommend it for all patients. As Alyssa mentioned, it's becoming the standard of care. You have not only the ploidy detection, but you also have the additional QC features. So some clinics will order it for all their patients because they see benefit in the whole package of PGT-A Plus. But there's also indications if you wanted to maybe select certain patients. For PGT-A Plus, you could choose those that have indications such as abnormally fertilized embryos, like we talked a lot about today. Other indications, maybe Alyssa, you can talk on the clinical side, but I think that would be probably the biggest clinical indication outside of just using it for everybody.
Sure, and I'll break it down a little bit. So PGT-A in general, I think, would be indicated for patients with advanced maternal age, and that would be similar for PGT-A plus. If we're thinking of PGT-A plus versus standard PGT-A, I think it gets a little bit more nuanced, but obviously if there's abnormal fertilization, please use a SNP-based platform. Don't just send us these biopsies expecting that we're going to be able to count chromosomes and detect ploidy. So that would be a really important use for PGT-A plus with the SNP technology. Patients may have had a previous molar pregnancy or previous pregnancy known to have triploidy. Most of the time, this is not recurrent and it wouldn't be a strong indication to do PGT testing. But if your patient is already doing PGT testing, we can provide that additional reassurance that that we could detect ploidy with the SNP-based platform. And then the third indication would be kind of what I mentioned, where you run PGT-A maybe with a standard platform and you see this stepwise XXY profile. It kind of looks like a triploid embryo. We think it's probably triploid. You don't have to do plus. You can just repeat the NGS-based technology and see if we see the same profile again. But if that's really what we're looking for, if we're really thinking that this could be a triploid embryo, PGT-A plus might be the best test to run for that patient.
Yeah, and you were mentioning, Alisa, regarding molar pregnancies, and this was something or a limitation that always, when a patient has a molar pregnancy, the physicians used to ask us, "What can I do for the next cycle?" And we used to say, "We cannot do anything because this is a limitation of the technique." Now we can say that we can do something for them. Okay, perfect. Thank you very much to both. There's a couple of questions that I'm gonna put it together because I do think that this is for the next webinar. There's Alisa, you said that you would talk about contamination and cohort check in the next webinar, but can you give us a small teaser? And related with that one, there's somebody commenting, recognizing that this talk is focused on ploidy abnormalities. My question might be outside the scope of this talk. Do you have updates to share from internal SMART PGT-A Plus data, incidence of contamination reporting, sibling mismatch, and so on? So I do think that the second question maybe is better for the next webinar,
Yeah.
but just a small
I can
teaser
give a teaser.
about.
Yeah.
Perfect.
I can give a teaser. So with the SNPs, there's two different algorithms that we run. One is for ploidy and one is for the cohort checking. For a really good ploidy detection, you have to be able to exclude the possibility of contamination. So contamination and ploidy are actually done under the same analysis umbrella. So it's very important to be able to detect contamination and differentiate that from triploidy so that if we say triploidy, we're confident in that result. And then the cohort check is its own analysis. In our next webinar, we will talk about some more internal data where we saw that stepwise XXY profile. These embryos were rebiopsied, and it didn't show the same stepwise XXY profile again. We ran additional analysis on those first biopsies, and we were able to confirm that they were contaminated. So we'll tell you a little bit more about that in the next webinar. Obviously, the clinical impact of that is that maybe now these are transferable embryos, and we really don't want to be excluding embryos unnecessarily. That's not the point of PGT-A testing. Angela, any other sneak peeks that we want to talk about today?
Without giving away too much. So I can comment on the rates. So the rates for contamination and mismatch, cohort mismatch is very, very low. So these QC features are intended to provide further assurance on your results, not necessarily be something you would see a lot or see very frequently. So both of the rates are very low.
Much less than 1%.
Yes.
Okay, thank you very much. There's something specific about, Angela, your presentation when you mentioned 25.9% were euploid from 3PN embryos. Did this come from ICSI fertilized or standard insemination fertilized?
It's a great question. So in that paper, they used a mix of both.
Yeah, they didn't mention, right? And we suppose that probably it's more coming from ICSI because the use of ICSI it's higher, but they were using both. And any difference in euploidy rates?
Euploidy rates on ICSI versus conventional, they didn't split. They didn't differentiate on that.
They didn't differentiate that. Perfect. Thank you, Angela. There's another question, and I would like to say hi to my friend Kim Pomeroy, asking, has an offspring with a chromosomal abnormality, mosaicism or an haploidy, ever been traced back to a PGT-A embryo? I guess this is something related with a possible false negative. And has a genetic disease of mosaicism or an haploidy ever been detected from an aneuploid or mosaic embryo?
If this question is about mosaicism, we have other talks on the topic. When we detect mosaicism in an embryo, we don't expect it to persist throughout the pregnancy or to be seen in a live birth. So it can happen. There are case reports of it happening. So the case reports are amounting. We can, show a list. Manuel Viotti has a registry. There's other case reports and publications showing the chance of persisting mosaicism. It's not zero, but it is low. So when we counsel patients, we tell them that for a mosaic embryo, there's about 1 to 2% chance that mosaicism will persist, resulting in miscarriage. So they should consider prenatal diagnosis, if I understood your question properly.
Yeah, I think so. Actually, last week in the IFFS Congress in Tokyo, we had Svetlana Rechinsky giving the data from Manuel's Viotti and from the consortium that they are getting. And so far, if I can recall properly, it's 1.2% of the cases when mosaicism was detected on the embryo and transfer that persist on the POCs, on the prenatal test. And actually, I think that it was like 7 cases so far.
Yep.
Okay, perfect. Thank you.
Most babies are born healthy, but not all babies that are born healthy have had karyotypes. So they are seemingly healthy. I think that's kind of the status of the field right now, is that we need to do some more long-term studies. And again, we're engaged in research with some of our clients to look at these more long-term outcomes of mosaic embryo transfer.
Absolutely. There's another question coming from a user of PGT-A Plus that say that decrease was observed over the time in the number of non-informative ploidy results. What could be an explanation? The number of SNPs evolve, or?
Yeah, that's a great question. It's true that the frequency of non-informative ploidy has decreased over time, partly because we've made improvements to our algorithm. Ploidy detection has just gotten better as we've learned how to manage SNP testing better. The other thing is that we made a clinical decision not to report ploidy for aneuploid embryos. So you may have noticed in the paper that Angela presented that only euploid embryos were tested for ploidy in the first place. And that makes sense clinically. Aneuploid embryos may also have triploidy. But if the ploidy analysis is not informative and we know from the NGS results that embryo is aneuploid anyway, is there any merit in introducing that level of uncertainty when we know that this embryo isn't a good candidate for transfer because of the aneuploidy? So we made a clinical decision not to report ploidy for aneuploid embryos. So if it's non-informative, you wouldn't see that either.
Thank you, Alisa. There is one technical question regarding the SNP platform. There is the potential to catch up uniparental disomy, thinking specifically on chromosomes with UPD disorders.
Not currently, something that we're looking into, but we don't have it right now. One of the decisions that we made with our PGT-A Plus test was not to get samples from patient and partner. So we only get DNA samples from the embryos themselves. So without that, it's a little bit tricky to get UPD analysis, but it's something that we're considering and looking into.
Thank you, Alisa. Yeah, I guess that would be great. But as you mentioned, and thinking clinically relevant, we decided not to get the samples from the parents, but only with the embryo. We are going to be able with the SNPs panel to detect ploidy and to do the cohort check and also the contamination. Okay. Talking about contamination, and this is something that Angela, Alisa, we have been discussed like several times, and it's about you're smiling already. It's about the term. It's a better term for contamination. Contamination sounds like from bacteria. What is your position, your thoughts about this? I have my own, right? But what is yours?
And I think this might be a good question to dive into in our next webinar series too as well, Nasser. But essentially, I think it's worth making the point the embryo is not contaminated. The embryo is probably fine. So there's no bacteria in the embryo that we're worried about. That's a different kind of analysis. It's that the sample that we're looking at has a quality exception, and we need to make sure that the sample that we're testing reflects and represents the embryo and not something else.
Yeah, Angela, I do think that your thoughts are in the same way, right?
Yes, usually when people ask that question, that is where they go, is they think it's some sort of bacterial contamination or some other source. So usually what we say when we refer to contamination, it's non-embryonic DNA. So the more common sources of this can be maternal cumulus cell contamination or anybody who's handling the tubes. But again, more to come probably in the next webinar.
Perfect. I will have more questions, but for the sake of time, I think that we need to close the session now. Thank you very much, Angela and Alisa, for your participation. I would like to have like 30 seconds for each of one of you saying your just last words regarding the webinar that we just have today.
Angela may
Lisa?
have frozen. Do you want to say your last words, Angela? Not last words, but last thoughts.
Thank you. Be holding are really going to help answer a lot of questions that we've been hearing in the field.
Oh,
Webinars are a really great source of information.
I'm afraid you cut out, Angela. I'll go ahead and say my last thoughts, which is just, again, to emphasize that we have genetic counseling available. I really feel that pre-test counseling is essential for patients to support informed consent and a better experience throughout their journey.
so again, thank you very much, Angela and Alisa, and thank you all of the attendees. We will get back to you with answers to your questions. And we hope to see you all on August 13th. Not to me, I will be on vacation. But again, thank you all for being in this webinar. Thank you, Elisa, Angela, and I wish you all a great end of the day. Thank you.
Thank you. Bye-bye.
Bye-bye.